There was a time when people said, I don't believe in methadone because it's just swapping out one addiction for another, or I don't believe in medications for substance use disorder. I only believe in the 12-step approach. What we know now is the evidence says using a variety of approaches is going to work better, and that in fact, when people use a medication for an opioid use disorder, whether it's methadone, whether it's buprenorphine naloxone, or whether it's long-acting naltrexone, they do better. They have more days when they don't use opioids. If they do use opioids, they use less, and they're less likely to have an overdose death. That's the kind of scaffolding on which all the rest of their recovery can happen.
Very common aphorism in chemical dependency, which I still adhere to today, is there's no one thing that works for everybody, but for everybody there's something that works. And for some people, the substance buprenorphine or Suboxone can be beneficial.
It came a time after my last overdose, and I'm just like, okay, so something has to change. I can't keep trying the same thing over and over and it not work for me. I have to look for something else. So what I did was I signed myself up for intensive outpatient, and I started learning about what does it actually mean to be on medication assisted treatment. It took away the fear that I had that I was going to use again and overdose again ultimately. So when I am on MAT, Suboxone specifically, it takes that away so I can think about other things.
These medicines can be given just by themselves to people, especially with opiate addiction, and they decrease the death rate by more than 70%. So all by themselves, these medicines can be very useful from a harm reduction, from a avoiding death perspective.
And in 2020, the American Society of Addiction Medicine actually kind of made a treatment recommendation that there was enough evidence to say every treatment program should involve one of those medications, and preferably the one that is going to be the most likely to be a good fit for a particular patient. Sometimes we don't have that flexibility, but when we do, we could say use any of those medications. They're all going to be helpful for the patient.
Dosing, frequency, duration, induction, those things will change on a fairly common basis, especially today when there's a lot of research being done. But remains true and changes much more slowly is first our understanding of the biochemistry involved, the neurobiochemistry, the socioeconomic factors, the psychology of chemical dependence. Those change more slowly, but do change. And what changes least frequently is why we do it. And the reason we do it is because the person with chemical dependency is the human being that has a right to care that can help them live a life that they choose to live rather than have their illness control their life.